Good afternoon. Welcome back. This week we're in week 12. We're learning about the self and mental health. And in this class, we'll talk about mental health and mental illness. And we'll take a closer look at mood disorders. I have posted the lecture 1 video. If you were in class on Tuesday, please watch it from the 1 hour, 16-minute point onward. Covers stuff about personality that is relevant to the assignment and the quiz. I have posted assignment 3. It contains self-reflective pieces on goals, adaptive behavior, your next steps forward, and then those class 1 activities on personality. And you're very welcome to reach out if you want any kind of help or with interpreting scores, so particularly on the Big 5 test. I have not yet posted the rubric. I haven't written it yet. You're able to work on your assignment, so you can get ahead if you want to. And I'm hoping that I will post the rubric probably Friday or over the weekend. I do want to give the TA as much time as I can to get the grading done before the final grades are due in a couple of weeks. At the last class, I was interested to know about your experience with the adaptive learning assignments. And most people put up their hands to say, yes, they like them, keep doing that. And then a couple of people had constructive feedback, and I was interested in that and in hearing that. But then I realized I forgot to ask you guys who said that you liked it, why it worked for you, right? Why should I keep doing that? What did you like about it? Yes.
That was just pretty straightforward. It was just just complete all the questions, get 100. It tells you what it has to be your time. Just putting it out really easy.
Okay, so you like the format of it and the fact that it gave you some bonus points. Was there anything else worthwhile about it?
Pick them off the top of
Ooh, interesting. Yes.
It gives you percentage of where you need to work on. So say one aspect you got 100 on it, and the other aspect you got 50 on it, you know where you need to focus.
Oh, so it gives you a sense of where the gaps are. Any other reasons? If there's no substantive value to it and it's just we just like it because it's straightforward bonus points, I can come up with better activities. Should I be doing that? I see blank faces. So I'm getting the sense that the actual value of it to you, the inherent value, might be questionable. I'm not hearing people say it was really useful, but I did see a lot of hands to keep doing it. And I'm hearing that sort of more about points or grades. Yes.
Yeah, I think the layout, I don't like the layout, but I just like it as extra bonus points.
Okay, so I'm hearing that it's kind of a bonus point thing. Thank you, that is useful feedback. Today in lecture, we'll talk about mental health, mental illness, medical versus social models of illness and disability, and then we'll delve into mood disorders. Content for today does include discussion of suicide, non-suicidal self-injury, stigma, religion, and there are some explicit images. On that note, I have a question for you. When was the last time you felt amazing? I know what you're doing. Have you ever felt amazing? This is a well-being question or a mental health question. You've never felt amazing. It's in the middle of a really dry psychology lecture. Yes.
Kind of amazing are we talking about? Are we talking about like physical or just like?
You feel really good.
So We're talking like mental health as well, like you're in a good headspace.
Yes,
Okay.
absolutely. Apparently this is a hard question. What can I think of? Have you ever been like thirsty and you have that first gulp of a cold glass of water? That can feel amazing. Sometimes, like, I know I've run along a beach, all the wind and the waves, and that felt amazing. So I'm going to say running, and sometimes that first sip of tea. Yes.
Walking out of your last exam.
Walking out of your life, that is a great feeling, isn't it? It's a tremendous relief. So walking out of an exam. And that's kind of about accomplishment. Anyone else? Yes.
Sometimes you feel amazing after you go for like a really long hike or something like that. It's
Yeah.
really accomplished, but it's not lasting. But in the moment, you feel great.
Yeah, like all those endorphins. So physical activity, and there's more than physical activity there. It's also being outside. So physical activity, being outside. Maybe you're hiking somewhere beautiful, and you're like, wow. In nature. Definitely stood on top of a mountain and looked down. That was an amazing moment. Anything missing? Yes.
Maybe engaging in a hobby that you enjoy?
Yeah. So doing something that you love. Like a hobby. I love dancing. Dancing feels amazing. Doing a cha-cha, spinning around. Yes?
Could it be conquering a fear?
Conquering a fear? Yeah. If you just do something that was a huge challenge for you and you overcome it, yes, that sounds like it would feel amazing. I can't really argue with you about what makes you feel amazing. Conquering a fear. That's like showing courage. Anything else? Yes.
I'm always like super happy when I can start a new book.
You can start a new book. So that's going with activities, doing something you love. So for somebody, their hobby might be dancing or hiking, and for you, it's reading. And it sounds like, oh, it's a new book, it's a new adventure. So novelty, adventure. It's a lot of diversity here. I'm going to throw out that I feel amazing when I'm with my friends. So these are all really different because they reflect different values. So what is mental health? Mental health and mental illness aren't just opposites of each other. So mental health is defined as a person's condition with regard to their psychological well-being. So what is well-being? Health is well-being. Now we need to know what well-being is. According to the Centers for Disease Control, they say mental health includes your emotional, psychological, and social well-being. So now we have to ask what well-being means. Well, there are many different theories. So some people have hedonistic theories of well-being, where hedony is the daughter of Psyche and Cupid. And Hedonistic theories would say that it's about pleasure and having more pleasure than pain in your life. But not everyone agrees with that, because these are all based on values. What does the World Health Organization say? Well, they say that mental health is a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. Being happy is nowhere in there. Feeling good is nowhere in there. Being normal is not in there. So there's all these different theories of what well-being is. And if you try to get to the heart, to the bottom of them, then they all get at the idea that it refers to what is intrinsically good for somebody and having that. But you can get very philosophical about what good means. And that goes back to values. And there are different values and conflicting values and competing value systems. What's good is also relative. So what's good for me might not be good for you. And it's socially constructed, right? We as a society also establish and decide what is good through a process of dialogue. In this happy ending to the story of Psyche, there's a big focus on having achieved a state of order and peace that results from everything being in order. The conflicts are all resolved. Everyone and everything is in its place. Everyone's doing their job properly as assigned, right? And there's also naked feasting. This is one vision, one idea of well-being. This might be your thing, or it might not be your thing. You'll encounter many other and many different views of utopia. So mental health is not the opposite of mental illness or the absence of mental illness or suffering. They're pretty different concepts. Mental health, which is well-being, is more about living your life in alignment with your values, whatever they are. Are you driving the bus in the right direction, where the right direction is the direction of your values, or are your passengers taking you off of it? Okay, and you feel amazing, reflecting a lot of values, right? Like courage, like adventure, love of nature. According to the American Psychological Association, a mental illness is a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. Thoughts, feelings, actions. There is a clinically significant disturbance. What does clinically significant mean? Yes. Absolutely. That is exactly what it means. It means that it interferes with your ability to function normally. It's maladaptive. Okay. There's going to be a lot of social construction behind what is maladaptive. So you know what adaptivity is? It's about being ready to use your resources in ways that get you the results that you want. So if you're acting maladaptively, maybe you're not ready to do this. Maybe you just don't want to do anything at all. And it doesn't matter if you have the skills, and it doesn't matter if you have the resources. You don't even care about the results. It might mean that you are not aware of your resources or how to use them appropriately. Maybe you are using them to undermine yourself. Maybe you are corroding them, right? Maybe the way that you try to handle things using your resources is actually making things worse. And fundamentally, you're not getting the results that you want. And a successful result depends on context, on what you value, on who has the power to judge an outcome as successful. So there's plenty of construction here too. So the person's behaving maladaptively. Now, what are we going to do about it? What are some things we've done historically to address mental illness in our communities? Yes. Yes, they tried doing that. It didn't work out so well. There was also, do you know what is lobotomization?
To make a long story short, it's when doctors basically would take a long metal rod, stick it up to the eyelid, and pierce the prefrontal cortex, and just scratch it off.
And the idea is that now the cortex isn't being ruled by these emotional parts of the brain because they can't communicate with each other anymore. And the results of that were not very good. People were quite seriously harmed. There's a very ancient practice of trephining. And so we think that maybe people used to make holes in people's skulls to let the evil spirits that were in their head come out. What else do I have up there? These are from Europe in the Middle Ages, and villages might have something called a lunatic tower. So you could put all the lunatics together in a tower. Later on, these might have been grown into our first mental asylums, into a hospital setting. That might be a bit more like a jail kind of setting. So what you think the problem is and how you frame it, and that involves a whole lot of social construction, determines the solution that you design. Okay, so if it's caused by an evil spirit, well, then you have to make a hole to get it out. You have to do an exorcism, burn the witch. Like the straitjacket, like what's that for? Yes.
Mainly just for containment, if not just.
Yeah, I think that's a good way of looking at it. It kind of says this is a person that might harm themselves or others, and we have no idea how to deal with it, and we don't have the resources to deal with it. Let's tie them up. And people can be quite injured by straitjackets. They can dislocate arms. This is a picture here of another pseudoscience, and this was from, I don't know, 18th century. It was called animal magnetism. So what's wrong with you is some imbalance in your animal magnetism, and we can balance that energy. It was probably more like hypnosis. In ancient Greece and Rome, there'd be people who went into trances and said things that could be seen as off the wall or possibly prophetic. Beware the Ides of March. They were the soothsayers, the oracles. And the oracles were priestesses of Apollo and were some of the most powerful women in the classical world. So we didn't say that they were crazy. They're soothsayers. There's a social context where that same behavior that might have got you put in the lunatic tower somewhere else or into a straitjacket is being approached in a very different way. John of Patmos had visions when he lived on the island of Patmos. He heard voices that other people couldn't hear. He had visions, sort of seen things that other people don't normally see. And his vision is written up, and you can go read it. Many people have. It has horsemen and beasts and angels and lamps and prophecies. It's difficult to follow it. Okay? John of Patmos is the author of the Book of Revelations. Many religious figures would meet criteria for what other scientists would call a delusional disorder if you did not believe that they're really having a divine encounter. So if you are not a Mormon, if you are not a member of the Church of Latter-day Saints, then you probably don't believe that Joseph Smith Jr. encountered the angel Moroni and was given golden plates that he could read through his hat with the assistance of a clear stone in the bottom of the hat. But there are many people, many sane, productive, good people who would never agree that that event was anything but a true divine encounter. So why am I telling you this? It's because it underscores that there is social construction behind what we call a mental illness, even if the symptoms are very, very vivid, and different people will call the same bunch of symptoms something else. Okay? Some people will say, oh, that person is delusional, and some people will say that that is a true leader. Until the 1970s, homosexuality was seen as a diagnosable mental disorder. It was an official mental illness in the APA book of mental illnesses. That's the book that contains the rules that decide whether something is a disorder or not, and which disorder it is. Now it isn't. Not here, not today. But in other countries today, it is still medicalized or criminalized, treated or punished. It was not seen as a problem in the classical world. Neither was pederasty, and that would in fact be illegal today. Right? So sometimes it comes down to framing. Let's say that you just cannot focus in class. You want to, you really, really want to, but you can't. And you try and you try and you try, and you can't. Is that a disorder that needs to be treated? The human attention span for a task that's not unduly challenging is 20 minutes for adults. It's less for children. Listening to a lecture, taking notes on a 75-minute monologue that's like a fire hose of information is more challenging than that. And I have to keep going whether you're keeping up or not. And in fact, I have no idea if you are. But this isn't the only way teaching is done. Plato and Aristotle had a walking around thing. It's called the peripatetic school. And Aristotle was really the first faculty member. So he would walk when he was giving lectures, and some students would come with him and they'd talk about it. And you can only do that with a fairly small group, right? Otherwise, people who are too far behind can't hear. That was a different way of doing things. And would you be learning better if we were going for a walk, maybe outside and talking, and you had more of a chance to participate? So is the problem you, or is the problem the system that were built that maybe you're assuming works, but doesn't actually work? So we assume that the dominant system has truth and rightness and goodness. It defines those qualities for you. It tells you who the good apples are and what they're like, and who the bad apples are. And what I'm conveying is that it's a social model. Seeing the kind of questions that I'm asking you now are getting the idea of a social model of mental illness or disability, making it more about the environment we build together and how well that works for people. The medical model, which absolutely also has its place, is the concept that diseases and psychological disorders have physical causes that can be diagnosed, treated, in many cases cured, and often through treatment in a hospital. And back in the day, people were very nervous about sex, and they had good reasons for that, because they didn't have the understanding, knowledge, treatment of STIs that we had today, right? It was much more unsafe. And syphilis was a big fear. It was the great pox. It was known to be associated with sex. People knew that that's how it got spread around. It was also associated with madness, because as that disease progresses, it affects the brain. And people have all kinds of disordered thinking, hallucinations, etc. It damages the brain. And it was the subject of mystery and fear and taboos. To the Turks, it was known as the Christian disease. In India, the Hindus and the Muslims named the disease after each other. So as syphilis advances and infects the brain, it leads to psychiatric symptoms, delusions, dementia, mania, depression, a whole basket of them, right? Depending on what part of the brain's being affected. The bacterium that is responsible for syphilis was isolated from neurosyphilitic people's brains in 1905. And the treatment was discovered very soon after. And that really impressed us with the idea that mental disorders can have a treatable physical origin. Diagnosing a mental disorder is much more subjective than diagnosing many medical disorders. So let's say you have scurvy. Well, you can do a blood test for that and find out that your vitamin C levels are abnormally low. And then we can give you some vitamin C and you'll get better It's way more objective. This is the diagnostic criteria for depression. You see that the clinician has to think through, okay, do we have 5 or more of these symptoms in the same 2-week period? And one of them has to be depressed mood, and another one has to be loss of interest or pleasure. And different clinicians that are talking to you, one might say, yeah, yes, this meets criteria for depression. And another one might say, no, I think this is dysthymia or something else. Okay, they won't agree with each other. I think they would if it's maybe a very severe case, but there's a lot of subjectivity there. Okay. So major depressive disorder requires that the person has over 2 or more weeks, 5 or more of those symptoms, and one of the symptoms has to be depressed mood, and one of them has to be loss of interest or pleasure. Then there are people who tend to have a chronic low mood over time. Okay, it's like a mildly depressed mood, and they might do that over years. And we call that persistent depressive disorder. Another term is chronic depression. So overall, instead of being a big depressive episode, it's like a milder state of low mood. And many people who have that don't seek treatment because they might not bother them, for instance. And for some people, depressive symptoms have a seasonal pattern. See a bit more of it in the winter. Bipolar disorder is when these periods of depression alternate with periods of really high mood, where the person is feeling amazing, but it's not happening on like a minute by minute basis. It's not happening on a day by day basis. This is a cycle that takes place over weeks. And mania is a hyperactive, wildly optimistic state where people can show dangerously poor judgment. So they might go on top of a building and say, I'm going to fly off the roof, and they think they can't. And so it's maladaptive because you really can't. But it's also associated with creativity, and there are many famous artists who produced their great works during a period of mania, where they're just writing and composing like crazy, and then after that, they burn out for a while, and then they're back. Bipolar disorder is much less common than major depressive disorder, but it can be more dangerous, and there's also a bigger association with suicide. Certain mental disorders have more of a genetic basis than others, are more heritable. There are 2 disorders that are pretty cross-cultural and universal, and then other mental illnesses can be far more socially constructed. But the 2 that are the most universal and cross-cultural are depression and schizophrenia. So you can see over here that like bipolar disorder has a high heritability coefficient, so does schizophrenia, but anorexia, which is more cultural, it's lower. It's actually lower for generalized anxiety disorder as well. Okay. But twin studies tell us that if one twin, let's say, has depression or schizophrenia, then there's a pretty high chance that the other twin will as well. So there is some genetic component. Every thought or feeling comes with some biological brain event. If you feel happy, there's something going on in your brain that reflects that. And so it shouldn't surprise you to see that in depression, brain activity is slowed. This is a PET scan that shows glucose burning, and it's showing that the brain is way more active in the manic state. It's burning a lot more fuel. And in the depressive states, it's burning a lot less fuel. Everything's slowed down. And in depression, we see lower norepinephrine and serotonin levels. So one way to treat depression is to give someone a serotonin reuptake inhibitor. So the serotonin doesn't get absorbed from the synapses as quickly. It stays out there. They have more. Lifestyle also affects people's chances of getting depression. Major depressive episodes are often preceded by a big stressor. maybe that big stressor is just a big challenge for you, and it sucks out all your energy. People who have kind of better diets, so more vegetables, have better health outcomes from that, and also have a lower chance of developing depression. Excessive alcohol use is correlated with depression. Alcohol does disrupt your sleep, and we know that disrupted sleep also disrupts mood. People with depression tend to make global negative evaluations about self, other, and the world. Okay, so there's another, in the case of a breakup, it's a very global to say, you know, without my partner, I can't live. I'll never get over this. And to internalize and say, and it was all my fault and what I did was terrible, instead of saying, well, you know, it takes two to tango. And yeah, I missed my partner, but I also have family and friends. So depression can also be associated with learned helplessness. We learned that in the learning unit with Martin Seligman and those yoked pairs of dogs. So given the same amount of electric shocks at the same time, the dogs who were not able to turn off the shock got turned off for them by the other dog, were the ones that acted depressed, right? They just, and when they were put into the new environment where their job is to jump over this little wall to get away from the floor shock, they just lay down and gave up. So they've learned that there's no point to trying. And that wasn't about the fact that they had more shock. If it was more stress, it's the stress associated with the lack of control. Depressed people tend to ruminate. So they think about something bad that happened over and over and over again. There is some adaptive value to that, right? It is identifying problems. It involves identifying and working through complex social problems. And the thoughts that you're having or realizations you're coming to are probably deeper than this, than, you know, will I ever get a job, or do I smell bad? So framing matters. And when something bad happens, you could frame it as like, this is terrible, or you could frame it differently. You could say, okay, this is a challenge, but I have resources to get over it. Depressed thinking can lead to a vicious cycle. So let's say you have a bad experience, it's a breakup, and then you have that negative explanatory style. It's all over, I'll never find love again. Well, you're gonna feel kind of bad. When you're feeling bad, you might have, well, you're likely to have more negative thoughts. We know that from memory. So if you're in a bad mood, you're more likely to remember bad things. So they're just kind of come at you. And then maybe you're feeling bad, so you don't go for a walk, you don't go to the gym, you don't go to the class. Chances are now something else bad is going to happen to you. You weren't there for your friends, so now they're mad at you. You weren't going to class, so now you failed. So you can stay trapped in that, get worse and worse. So therapists recognize this cycle and they work to help depressed people break out of it. And there's many different ways you can break out of it. You just need to break out of it. So changing negative thinking, that'd be a cognitive kind of psychotherapy, turning their attention outward, right? So less focus on self and let's talk about what other things are going on. And getting them to engage in more pleasant and adaptive behavior. If you get a depressed client to go out for a walk, they feel better. It's called behavioral activation. There could be a lot of different causes for depression. Depression is really a constellation of symptoms. And that constellation of symptoms could reflect many different causes. Right? Maybe it's the way you frame problems. Maybe it's some disorder in your serotonin system. Right? Maybe it's not enough sleep. It's not as easy as treating scurvy. There are drugs that people are prescribed to treat depression that can benefit people with mental disorders like depression and anxiety. They do not work or are not favored by other people. Some people will tell you, wow, this worked so well for me, it changed my life. Other people will say, stay away from that. And that reflects that it's so difficult to know what the cause is, and one person's solution might not be your solution. Most depressive episodes do get better on their own with no treatment. But that doesn't mean you shouldn't seek treatment, because then you could help it get better faster. Ever seen this? Yeah? So let's say that you have a medication, an antidepressant, and it's supposed to help your depression, and it comes with this warning that it might make you kill yourself. Anyone know what that's about? It's true. People fought to have that on there. Yes.
I'm not actually sure if this is the real reason, but from experience, when I first went on antidepressants, they really wanted me to be monitored when they started to kick in, because you do tend to get a lot more energy when you're coming out of that sort of depressive episode. And when you have a lot of energy, you might be spurred on to do things that you might not want to do.
That's exactly it. So a depressed person is going to have depressed behavior, thoughts, and feelings, right? They're going to have those three things. But changing their neurotransmitter systems so they have more serotonin is going to perk them up, but it's done nothing to change the thoughts. So now you have somebody who maybe had a suicide plan that they didn't have the energy to go through with, who now has the energy and they still have the plan. So when somebody is put on an antidepressant, they do need to be monitored, and they do need psychotherapy to assist with the thoughts. Okay, so it's dangerous to sort of change one thing without thinking about the others. The psychological model of mental illness comes to us from the idea of hysteria. Does anyone know what that is? Yes?
It was a diagnosis given to women when they were irritable or
Yep.
showing other signs of mental illness. It was just a kind of write-off,
Hysterical woman. Yeah, that's exactly what it is. So excessive, or what was seen as inappropriate, we just don't like it, emotional behavior was once seen as a diagnosable mental illness in women. And the ancient Egyptians attributed these behavioral disturbances to a wandering uterus. So the ancient, I think probably Greek word for uterus is hysterium. That's the root of hysterical. And so it's caused by this wandering uterus, or so they thought. And to treat it, the doctors would prescribe various medications or do certain processes. So for instance, they might put a strong smelling substance on a patient's vulva to encourage the uterus to return to its proper position, kind of draw it back. And another tactic was to smell or swallow unsavory herbs to make it sort of flee back to the lower part of the abdomen. So this is, anyone know who this is? Jacques Charcot was a famous, I think, French psychologist who studied hysteria. And he had these displays every Thursday where he hypnotized female patients and provoked these hysterical fits for the fascinated male public. And that included everyone from Sigmund Freud to Emil Durkheim, who's the father of sociology. Okay. And Charcot had about 4 star patients who were particularly good at performing his 4 stages of hysteria. So he was hypnotizing them. Hypnosis is a state of extreme suggestibility. And so he's probably giving cues that this is what you're supposed to be doing, like faint in my arms now. And they're doing that and probably being rewarded for it. This is the picture of Freud's office, and this is the couch that the client would lay on. He would sit over there and psychoanalyze and take notes. You can see that picture there of Charcot over the couch. So if a disorder like hysteria or glove anesthesia are somehow in someone's head, then that leads to the need for psychological treatment, psychotherapy. And the psychotherapist gets in your head and analyzes the workings of your mind and then helps you resolve your unconscious conflict in some way. That's the idea. There is cultural variation in what we call mental illnesses. So some are more culturally situated. So one of them is eating disorders. Oh, in different contexts, body weight means different things about social status. Here, being thin is associated with higher social status, more self-control, but in Mauritania, being thin is stigmatized, and being bigger is seen as more beautiful and desirable, and higher status because it means you have more access to food. In the Far East, where people can be very conscientious and hardworking, have Karoshi. Karoshi is occupational sudden mortality. You work so hard that you die. And this, so 20% of Japanese employees are considered at risk. And this is a culture where so many people wanted to be kamikaze pilots that they put extra people in the cockpit for emotional support for the pilot. People were lining up because there's a strong value of contributing to society, even to your own destruction. Karoshi is not a recognized mental illness here. Okay? We don't seem to have that problem. And we're a much more individualistic society. So sadly, suicide affects about 1 million people worldwide. There are important differences between suicidal ideation, attempts, and completion. Suicidal ideation is quite common. You have probably thought about killing yourself at some point in your life. That's quite common. It is much less common to have a plan, like a real intent, and then to actually try. And there's gender differences in completed suicide, where men be a bit more task-based, use more violent methods, more lethal methods, and their attempts tend to be more successful. Women tend to be more likely to use poison, which does not work as well. Suicidality is associated with depression and also with impulsivity. Sometimes people who are not depressed kill themselves in an impulsive way. The depressed side of things is associated with a sense of being a burden to others and with feeling disconnected. And the group that has the highest suicide rate is older adults. So maybe people of your grandparents' age. You hear about it more with teens. So suicide is the leading cause of death for teens, but that's because of the lack of availability of other competitors for death. Most teenagers who die because of suicide or an accident because they're not getting heart disease, they're not getting cancer generally at that age. Those things affect more older adults. However, the highest rates of completed suicides are in older adults, and they may be very lonely. They may feel very disconnected. They may feel like a burden, and they may be struggling with health issues as well that can sap their quality of life. Then there's non-suicidal self-injury, which talks about how social, emotional pain is read in the same parts of the brain as physical pain. And imagine if you have terrible emotional pain. Well, one way to manage pain is to sort of distract yourself from it. And we have different expectations or experiences about different kinds of pain. And so let's say that, let's say you're getting your COVID shot, and it's a little bit scary, you don't really know what's in it, and it feels kind of gross, and you might find yourself, let's say, digging your nails into your arm. And that distracts you from it, even though it hurts, but it's a safer kind of hurt. You know you're causing it to yourself, right? You know it's pretty superficial, not that bad. So you might find yourself doing things like that to distract yourself from a worse kind of a pain. So what other differences are there in depression? There are national differences. There's countries that have higher suicide rates. Those personality differences do vary across cultures. So there's certain cultures where there's more people with higher neuroticism scores. And that I was looking at a paper on sort of the genetic basis of neuroticism. And it was done on a sample of Russians. And in that paper, like 55% of the Russian women met the criteria for depression. But now I was trying to think, is that a genetic thing, or are there some big social factors there as well? And there are gender differences, which we've discussed. So women have more suicidal ideation, they have more attempts, but men have way more completed attempts. And then there are temporal differences, right? Like with season. And it's the seasonal differences are not what you expect. I think spring is actually the season where you see more. Like you think it's winter, but it's not. I think it's spring. So anxiety, let's move on to anxiety. Anxiety disorders are marked by distressing, persistent anxiety, or maladaptive behaviors that reduce the anxiety. It's okay to be afraid. It's okay to have anxiety, but it becomes an anxiety disorder when the distress is more than you can deal with. And one way to deal with it is by reducing the anxiety and the distress. Another way to deal with it is through distress tolerance, saying, I'm anxious, and that's okay. I'm going to keep going. But there are maladaptive behaviors that can come out of anxiety. So if you are so anxious that you can't leave your house and you can't have a job, you can't get through your day, now we're looking at an anxiety disorder. Some people have anxiety, just generally high anxiety, and they worry a lot, and they're anxious about everything. It's pretty unfocused, and that's called generalized anxiety disorder. The person's continually tense, apprehensive, and that state of autonomic nervous system arousal, tense, the heart's beating. Panic attacks are when somebody has a sudden episode of intense dread. I had panic attacks when I went off an ADD medication, cold turkey, and they were really scary. Like I thought I was like dying. It felt like there wasn't enough air in the room. I thought I was going to have a heart attack. I respect them. Those were frightening. So there's a sense of doom, and it really feels like you might be dying or you can't breathe. And there can be some hyperventilation behind that. So one way that people can get out of a panic attack is to regulate their breathing, even to breathe through a straw, so they're not hyperventilating. Phobias are a persistent, irrational fear and avoidance of a specific object, activity, or situation. And note the emphasis on irrational fear and avoidance. So it's something that's maladaptive. It's okay to be scared of mice. Mice carry a lot of diseases. You don't want them in your food. It's okay to jump back and see one running across the room. But if you feel like you can't be in a building because there might be mice, or you can't touch any food because maybe mice ate it, now you're getting into a place of a disorder. It's okay to be scared of spiders, but if you can't go outside because you might encounter a spider, now we're getting into maladaptive behavior. When you look at what people have phobias of, they tend to be things that are ancestral threats, things that it would be adaptive for our ancestors to be afraid of, right? Water, because you can drown in it. Blood spreads diseases, means there's probably some violence around. Being alone, that's when you can get attacked by a saber-toothed tiger. Enclosed spaces, you can get stuck in them. Animals, they can really, really hurt you. Heights, you can fall off them. So it makes sense to be afraid of these things, but we don't see many people who have phobias of the things that kill us now, like cars, cheeseburgers, being indoors all the time, TVs. Maybe we haven't had time to develop them. I really like this picture. Sometimes I think the jokes in the book are in fact funny. I like this one because it really gets at the idea of maladaptive behavior. So it is really adaptive to wash your hands, to, ask if other people you're about to touch have washed their hands, but like that is not the right moment. In that moment, grabbing his hands is the adaptive thing to do. So obsessive compulsive disorder is characterized by persistent, repetitive thoughts. And it's stressful to be thinking, did I leave the door open? Or did I lock the door? And the person can relieve that anxiety by going to check if they locked the door. Oh, good, okay, that's relief. Now I'll go back to my day. Did I really lock the door? I'm not sure if I turned the key properly. Okay, I feel uncomfortable. I better go check again. And checking to make sure that you locked your door is probably a good idea. Maybe it goes back to some evolutionary history of checking the boundaries of the territory, but it's a problem when it gets to the point where you can't get through your day because you have to check the door 100 times. Washing your hands is a great idea. It's a problem when you're spending all day washing your hands and your skin's coming off. So it's about the behavior, even if it was something that's originally adaptive, being performed in a way that's maladaptive. So these are common obsessive compulsive obsessions. So things like dirt or germs or toxins, something terrible happening. The compulsions might be excessive hand washing or grooming, repeating rituals, checking the door, checking the stove. Even things like checking over your homework to make sure that you didn't make a mistake. Once that trait itself is great, it's just being applied in a way that isn't working anymore. It's not getting the results you want. I remember a question from a young man sitting around over here about PTSD way back, maybe in week 1. So post-traumatic stress disorder is something that happens after a traumatic event. And it's characterized by haunting memories, nightmares, social withdrawal, jumpy anxiety, being triggered by things that remind you of it. And it lasts for 4 or more weeks after a traumatic experience. Now, here's a good question. What meets criteria for being a traumatic experience? So the psychiatric rules and the big book of rules are that the originally traumatic incident has to be life-threatening or sexual. And at one point, the sexual one wasn't there, it just had to be life-threatening. So social trauma, say from discrimination or harassment, actually doesn't meet that criterion, even though it seems to result in some very similar symptomatology. That can and does complicate access to treatment for people who need support. There can be a lot of hair splitting about what meets a criteria and who establishes and decides that this is the criteria. Now, sometimes if you're feeling anxiety, well, we know that an emotion involves a cognition and a behavior and a feeling. We can become very focused on those feelings. So maybe if you're anxious, you might feel some butterflies in your stomach. Maybe you get a stomach ache. And sometimes the things that people go to the doctor with, like, oh, I have the stomach ache, I have this twitchy eye, are representing stress. They're psychological in origin. Sometimes people who have even normal bodily events will have an anxious way of thinking, oh my goodness, I have a stomach ache, it must be stomach cancer. And you might go read the criteria for stomach cancer. Like, yeah, that happened to me. And the other thing happened. It's called medical student's disease. So illness anxiety disorder used to be called hypochondriasis. We don't call it that anymore. It's a disorder where a person tends to interpret normal physical sensations as symptoms of a disease. So how do we get anxiety? Well, we know from our unit on memory is that it can be taught. You can learn it, right? Little Albert learned to fear white fuzzy things. And they taught him to fear a rat, but he then generalized that to all other white fluffy things that they showed him. People can get stuck through reinforcement, that's operant conditioning, because if you're anxious about something, you can make yourself feel better through avoidance. So you're afraid that if you go out, you might have a terrible panic attack. Well, you can relieve yourself from that anxiety by staying home. So the avoidance has been reinforced, makes you feel better in the short term. In the long term, it doesn't work out. If you're worried that you left the door unlocked, make yourself feel better, you're reinforced for checking. Oh, it's locked. That feels good. And now when you're feeling that way, you want to do it again. And people are get stuck like that. We are also learned to fear things from others. Monkeys that are raised in labs don't fear snakes, but it's natural for monkeys to fear snakes out in the wild because they learn from watching other monkeys that, you know, they see a snake and they start screaming and running away. They learn that that thing is fearful. And did someone ever tell you that you need to really watch your bag when you're in a certain neighborhood or around certain people? Is that actually based on a real experience? Here's social anxiety. Let's look at the criteria there. Persistent, intense fear or anxiety about specific social situations because you believe you may be judged negatively, embarrassed, humiliated, avoiding those social situations or enduring them with intense fear or anxiety. Maybe you don't want to talk to strangers, speak in public, date, even go into a room, go to a party. Might not even want to eat in front of other people because they could be judging you negatively. Does this sound like, let's say we put a power lens on this. Does it sound like being in a relationship with other people that's based on equality? Does it sound like dominance or submission? Does this look like dominance? Like a dominant trait, way of thinking about the world? No. Does it look like one that's based on equality? Does it look like submission? Why are you saying yes?
There's nothing dominant about it. It's all fear.
There is fear. Fear of what? Fear of judgment. And the dominant person judges what is appropriate, what is right, what is good. And we're not going to meet with their approval. And they might punish us and we'll feel shame and humiliation. So it's almost like an indiscriminate submission to everyone and everything, because all of these people or systems could be judging you negatively. So consider that your pleasing obedience that gets the approval of others is a gift that you choose to give to one system, structure, person, whatever it is, that you judge is worthy. It's one that can be revoked, and sometimes it should be. There's no leadership without followership. You have some agency in who or what you bestow that upon, and it's one you can take away or decline. So ideally, the system, the structure, the person that you are submitting yourself to is sort of competent and ethical and has values that align with yours. Indiscriminate submission is not adaptive. You can't submit to, you can't please everyone and everything, because some of the people, systems, dominants that are judging you will have values that aren't compatible with yours, and they don't even agree with each other. Okay, they're all doing their own thing. And they might not be competent. right? They might not act in ways that are competent or ethical, and you can get hurt. They might not care about you. They might judge you unfairly. They might punish you inappropriately, and you burn with shame for all of them anyway. And you can't please them all because they don't agree with each other. Let's say you submit to one system, whatever, maybe it's a religion, and you're a good, true believer in that system. Well, you automatically were put in the bad books of another one. Now you're their heretic or their infidel. So you kind of have to choose one and choose it well, but it can't be everything and everyone all the time. This is paradoxical. There is a strong comorbidity between anxiety and depression. That means that if you're anxious, if you have anxiety, you probably also have depression. And if you have depression, you probably also have anxiety. And that's paradoxical because anxiety is about being all wound up, and depression, kind of the opposite of that. Anyone understand what might be going on there? Yeah.
Symptoms of your anxiety can lead to depression. Not wanting to go out of your house, not interacting socially, that can lead to depression.
Yes. Yeah, so now we're going to withdraw because we're afraid we're going to stay home where there's nothing and nobody and we're separate from our friends. I was not thinking about that, but I think that's a very good point. Yes.
Would it be just because you're so wound up with anxiety that you're getting more tired than usual?
Yeah.
As you're getting tired, you're getting more depressed.
Yeah, we talked about what that side of your nervous system does, that dumps glucose in your blood and it makes your heart beat and it shuts down your digestion and your immune system. Oh my goodness, that wears you out. Being anxious is really, it's pretty hard on your body. And so that, when you finally get run down, looks like depression. You saw that, had that graph about general adaptation syndrome. You can keep doing that to a point, and then you deplete your reserves. There is a gender difference, a pretty big gender difference in mood disorders. Note that this doesn't apply to bipolar disorders, but women are more likely to have anxiety and depression. And that's not true over their entire lifespans. It's more true during the childbearing years. That's where we see it. And it actually drops off after menopause. And women and men become much more like each other in terms of mood. There's an argument in evolutionary psychology, and keep in mind that evolutionary psychology is a very speculative field. You can't really prove whether it's true or not, but it's a way to think about things. But there's an argument that a younger woman's emotions are not adapted to her as an individual, that they're adapted to the mother-child dyad. Historically, women have done the bulk of the child raising. And human children are very vulnerable, very fragile, and take a tremendous amount of investment. Think about horses. They're born already able to walk. Human children aren't like that. They're born very immature. They're born so immature because those amazing human brains make for a really big head. And they're born at the point, not where they're ready, but where if their heads got any bigger, they wouldn't be able to come out anymore. And that's why it's hard, very hard and unpleasant for human women to give birth naturally. Labor is a lot easier for cats and dogs and rabbits. They don't have that problem. And historically, human women very often died in childbirth. And when that human baby is born, it really does take a village to raise him. Human infants and children are incredibly curious. They have that amazing developing brain. But it takes time to develop complex mental models of the world and how it works. If you have a baby and the baby sees something interesting, it'll just grab it and it'll pull something towards it, and it might pull something down on top of itself. You have a toddler in the kitchen and you have a bowl of boiling water. They'll be like, ooh, that's interesting. And they'll go and grab it and they might bring boiling water down on themselves. They do this regularly. You have to be watching them all the time. Okay. So the baby that reaches out to grab something doesn't know that she's about to burn herself or bring something dangerous crashing down. So one of the reasons that you are staying safe in this room is because over the last 20 years, you've learned social scripts for behavior that keep you safe. Even if you are not listening right now, you are following the script of sitting in your seat quietly, even if there's a party in your head. Now imagine if you're all like 2 or 3 years old, be running around the room, spinning on the chairs, climbing on the desks, falling off the desk, crying. You would want to show me your drawings and doodles instead of keeping them secret in your notes. You'd be sticking things up your nose, into the other kids' ears, taking your clothes off, pulling the cables out of the walls and sticking your fingers into the sockets. Kids do that. And if that kid's mother wasn't chasing him, he'd probably be running into the ocean and getting swept away by the wave. A couple of my family's acquaintance very tragically lost their 3-year-old daughter, and she died of a brain infection. They didn't know why. And they found out that she had just stuck food up her nose. They just do that because they're curious. They're like, what is this thing? And can I stick it up my nose? And then they do. And unfortunately is there for a while. And it's not just 2- and 3-year-olds. My daughter's 9-year-old friend was maybe taking a little bit too long in the bathroom. So I went and checked on her, and she was rummaging through the medicine cabinet and putting things into the bath just because it was interesting and she could. Like, she didn't mean harm. It's like, ooh, what's this? What can we do with it? That's the way a curious child thinks. And that's why medications come with those child-proof caps, because if they didn't have them, kids would do something sort of foolish with them, like maybe eat the whole bottle, even if it tastes bad. And so arguably, for the sake of the species, women are adapted to see irrational things coming before they happen. Children do incredibly irrational things unpredictably because they have not yet developed the faculty of reason. So there could be an adaptive evolutionary basis for what out of context looks like hypervigilant irrational fear. But maybe it could be being scared or being prepared to be scared and legitimately scared for the well-being of someone that is actually irrational and will do things out of the blue that make you go, what were you thinking? Sometimes we worry, is the bad apple also dangerous? Right? Are people with mental illness responsible for violent actions? Well, it's really hard to predict people's behavior in psychology. Right? Clinical prediction of violence is unreliable, and generally the best predictor of future behavior in a given situation is past behavior. But overall, most people with mental disorders are more likely to be victims than perpetrators of violence. That's not true for all disorders. There are some disorders that are associated with a bit of a higher risk of perpetrating something violent, and those include delusional disorders. So it's like paranoid schizophrenia. If you think that, oh no, the aliens are coming, and I think there was a case in Walmart, it was a while ago, where a woman went in with a gun, and she was not held criminally responsible because she thought that she was saving everyone there from the aliens that were going to replace people's brains with washing machines. So she was trying to help, but there was a very complex delusion that involved her acting violently, unfortunately. Okay. So since I have a few minutes, I'll talk about these instructor evaluations that are up on Brightspace. I do value your feedback, but just a moment, guys, because we're not at the end of class yet. I do want you to understand what these mean, because what you read in the notice isn't the whole story. So like all stories, it's kind of partly true, partly false. There's some spin. It's a narrative in a way. So the way this is communicated, the way that the questions are set up, it makes you feel like you're giving your feedback to a third-party overseer, right? Like, this is what Tanya's like and should change. In fact, they come directly to me after a few months, and nobody else reads the comments. And some instructors never open them because they don't want to read anonymous comments that sometimes people leave. There are 2 that go to the department chair, and they're very general, and you have a numeric rating. And so if I teach a course here, your feedback, I do care, but I do want you to know that whether somebody teaches a course is based on union membership and seniority within a union, Okay, so the person who gets the job is the person maybe on the top of the precedence list, and that's about how long they've been there. It's not actually about quality of service, right? It's not based on those ratings. Those never go to the union. So I do care though, and I am interested. So please give me good quality feedback that I can use going forward. So if something worked, why did it work? And if something didn't work, why didn't it work? Like, help me understand. And then I will do something differently. Okay, so Ramadan starts on Friday. If you observe Ramadan, then you can complete week 13 of the course after Eid. You have a quiz for week 12 due on Sunday. And for the next lecture, we'll be talking about schizophrenia and neurodevelopmental disorders. Thank you for your attention.